Hey everyone, this is the Nips and Sips podcast featuring me. I'm Dr. Jeremy Boyd and my partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about a second part of our shoulder impingement, more the interventions that we commonly use today, some evidence supporting them, and just ways guys get you better at treating the shoulder, the infamous shoulder impingement. But before I get into too much about that, Brandon, how's it going?
Going well over here. It is a crummy day,
It is.
raining and cold, dreary day.
Oh,
But other than that, still being productive here. Got my drink, except we'll be honest, I don't know if I will be finishing it today. I'm going to go light because I was out last night and had a couple too many there, and yeah. So, but
bad boy.
I have my blade and bow, so that's what
There
I'm
we go.
drinking today. What do you have?
The last of that winter series. We're almost into a year later of that winter. From that was last year, that whole white elephant thing. This is wood chopped chocolate stout from Smuttynose Brewing Company. So it's aged now a little bit. Chocolate stout. Figure it's crummy. It's cold. Might as well. I will. I'm a huge stout fan. Very excited about the stout that your employee Marta gave me. I'll pull that out on the next Crummy Day show. But I wanted to finally get this bad boy out of my fridge. So, cheers, everyone.
Very nice.
Because I'm partial to stouts, you give it 7.5. Standard chocolatey stout, which I've probably had 100 of these over the years. But it has a hint of chocolate, kind of coffee vibes to it, but not bad, not bad. 7.5.
What was the name of that one again?
Wood Chop Chocolate Stout from Smuttynose Brewing Company in, you know what? I have no idea. Hampton, New Hampshire. So maybe I'll go there one day.
Very nice. That one we had at that Axe and Arrow. Is that the name of the place across from
Yep.
your office? So for our audience, we just had a lumbar-pelvic course at
Very
Jeremy's
close.
clinic. Awesome weekend. After the first day, the whole group went to Axe and Arrow. Right, that's it.
Yep.
That Choco Stout I had. I don't know if I'm saying it
Yeah,
right. That was pretty solid.
that's Sal. I like that one better than
And I'm not a beer
this
guy,
one.
and I
But
liked it.
yeah, so
It was
on
good.
the Brandon scale, that must have been a close 9 then,
It
at
was up there.
least.
Yeah, it was up there.
Cool.
But I do want to try that one. But we're getting off topic here. Let's go back to part two of subacromial impingement syndrome. For those of you who are just joining us, we in the previous episode or part one really kind of talked about differential diagnosis, how to use certain tests to identify certain pathologies instead of just using all the tests that you've learned about the shoulder. Can we group things, cluster things, and only use certain tests when we're looking to diagnose shoulder pathologies? Obviously, here we're talking about impingement, but I believe we also went into tubs and ambry and multi-directional instability and things like that, and rotator cuff type stuff. But this episode is going to be more on the treatment side. So, Jared, what are some, I guess, some of your common go-tos and how they maybe became your go-tos? What has been your evolution
Mhm.
over 6-7 years, and now you're in a sports fellowship, so I'm sure you're evolving even more. So
Yeah. Uh, definitely a big evolution with this. Probably one of the more profound ones. Over if I looked at my initial start, um, wasn't as much direct access. Worked for a hospital group, and I was got the shoulder impingement, and it was pec minor releases for me, external rotation to the day they die, a little scap retraction. Everybody's retracting, and inferior and AP mobilizations of the glenohumeral joint. So that was a cookie cutter program,
Hmm.
and rightfully so. Not as many people get better all the way or 100%. Some people did, and those are those ones where I mentioned, like the shoulder symptom modification procedure last time. That's when everything makes the shoulder better. Doesn't matter what you do. Some people are just naturally going to get better. And we know from research there's a large biopsychosocial component to impingements. Some people just need to be seen by somebody for a quick little bit and just be like, hey, you're going to be fine. So understanding that, having those educations, but then following residency and everything like that, starting to transition towards, I think Scott Burns mentioned it. Um, he said he was teaching us a shoulder. He said he doesn't even do much shoulder mobs at that point. So that really kind of opened up my eyes, being that at that point, that's all I did.
Yeah.
Minus the little pec minor release and stuff like that. Starting to put a lot of emphasis into the T spine. That was pretty big for me. You kind of combine it with that shoulder symptom modification, but just understanding, deeper diving into the orthokinematics of shoulder motion and those sort of things, and paying respect to how much motion happens at the shoulder and the scapular thoracic joint during motion. I started diving more into doing just thoracic manipulations. It's evolved a little bit more specifically to each individual versus just let's light up the thoracic spine now. And then that transition where I was talking about, where it was mostly retractions for everyone. Everyone's got to bring them back and down, everybody. And then kind of realizing that's not how the shoulder works during the whole entire motion of shoulder, especially overhead motion, caused me to have to think about, a better way to treat each person individually at what area they're having problems, what part of the motion. So, sometimes people need upper trap work, need either, lower trap or serratus work. It's kind of diving a little bit more deeper into things. So definitely more of an emphasis onto some scapular work, both manually, which I've really come done more this last year than years in the past. We can talk
Mhm.
about that in a bit. And then, stop going to town doing a million rotator cuff exercises. Actually, probably doing less and less of that each year that goes by. But what about you, Brandon?
Yeah, similar thought process to you. I remember, uh, I guess, like, luckily I jumped into residency early on, so I didn't have too many. But I remember doing pec minor stuff, pin and stretch. I remember doing that. A stim to like the deltoid region, maybe posterior delt, infraspinatus. Watch it light up red. Things like that. Um, Trying to do joint mobs, which at the time I remember, and I think I said this last podcast episode, but I remember going to Scott and like literally raising my hand in the middle while he was talking. I was like, "Can we go over joint mobs?" Because I told him, I was like, they suck. I was like, I don't find them useful. I was like, maybe I'm doing them wrong, but every shoulder patient I work with, I try and mobilize, and they don't like it. And he kind of smiled and was like, yeah, we'll go over it. And just showed me just a different way to mobilize the shoulder that's comfortable. You're not closing down on it. I mean, most of us are taught bring it up to 9 degrees of abduction and just kind of push. And that just wasn't carrying over. I do remember trying to implement some thoracic mobilizations at the time, maybe even some manipulations, though they weren't that good back then. Just because I had read an article, and I remember reading Greg Cook stuff, and back then his FMS book, or movement book, I should say, and him talking about regional interdependence. And there was a thing on there that talked about the T spine is very interrelated with the shoulder and the scapula. And I was like, yeah, of course. Why does it? So that was like my early on, you know, foray into that. And like you, I moved away from it. While maybe I had half a kudos because I did thoracic mobilizations and or manipulations, didn't really treat the neck. I would say most shoulder
Mhm.
patients, let me see if I have a stat here. Most people with shoulder pain have neck pain as well. I think 80%. Let me see if I can find
Mhm.
this stat here. I think I have it up.
I'd
Maybe
say
not.
it's at least that. Just
Uh,
anecdotally, my experience.
I thought I had it in the presentation. Actually, I'm gonna add it to the presentation now. I thought it was there. The new course that we're working on, shoulder management. But yeah, about 80% of people with shoulder pain have neck pain as well. So clearing at the neck, incorporating neurodynamics has been
hmm
huge, especially over the past 2 years or so. Um, Looking at the scapula motions, we're talking about force coupling. I've over the years, and I used the analogy. I'm not sure if I used it before, but you have a 1800 Civil War cannon, and it's shooting off of a cement ground. I think I mentioned it last episode, but I'll repeat myself again. Versus using that same cannon on a little canoe in water. If you have an unstable shoulder blade or shoulder girdle, and you're trying to generate a lot of force, whether you're bench pressing or an overhead athlete, or even somebody carrying a kid or reaching overhead, things are going to get wonky and impinged. But it's that balance. I've also found that upper trap knot that a lot of people try and rub out and trigger point out and theragun out and trigger point out really is more weakness, and that's been something I've learned over the past year, and I don't know why I didn't make that connection sooner, because I made that connection sooner for the mid traps years ago, probably like 5 years ago, and for some reason the upper trap didn't come along, making that connection. Where actually those patients I try to I have them do shrugs, and I have them do it in a specific plane that doesn't have them come forward and use those anterior muscles, but can they slightly retract and come up so that shoulder is in line with the occiput and they're really getting all those fibers. So we'll dive a little bit deeper there into that. But do you have any articles that you want to share with us, or any case
Uh,
examples, Jay?
yeah. I mean, I don't have any articles up right now.
Okay.
I've been busy, as I mentioned before. I have a presentation for AOMP for anyone who's going. A poster presentation. Brandon, you have your classic manipulations one.
Yeah,
Is
so
it?
Kyle and Kyle Feldman, he's been on a show before. He and I are doing the third series, so there's a third year in a row we're presenting. The first year was on bringing the confidence back to spinal manipulation. The second one, which was last year, which you attended, was on bringing back confidence to upper extremity manipulation, and this year we're doing the lower extremity. So we're presenting that virtually.
Cool, cool, cool. So yeah, I don't have. I mean, I do have the impingement articles that I use. I don't have them readily up and those sort of things. As for case
We can talk
studies and
about it.
um, yeah, for case, I want to bring up something that just to kind of stir up some conversation, because a lot, especially with what we know of secondary impingement, we talked about this a lot of time, primary versus secondary. There's a big knock on, is asymmetries in the scapula fine or not fine? We know that most people do have asymmetries. Um, we know, like, especially like kids and stuff, they have winging scapula, and we try and do some things with that. Is it okay to have asymmetries? Or is it something that we should take a respect to or address? What do you think there, Brandon? And I'm just gonna put up a picture just for fun purposes.
Yeah, I'm going to say asymmetries are good. Obviously there may be an extent to it, but that's a great picture. And I was actually going to talk about that. See how his right side is sloped down. I'm guessing he's an athlete. I see that a lot in athletes,
Oh,
weightlifters. One side shrugs down a little or slopes down more. Overhead athletes, I see that. There's imbalances from just 20 years of life. People or 20 plus years, depending on how old the person is. That things occur. I don't think we should necessarily kill ourselves trying to fix every little thing, as long as that we get that person pain free at the end of the day. I think posture and symmetry kind of get focused on too much in our field, but no one's perfect.
Absolutely. I think that's a great answer. There's going to be some things that we just aren't going to be able to correct from an asymmetry standpoint. Try working with bodybuilders, and I had a niche of bodybuilders at one time. There's just going to be things that, you're going to be shifted a little bit different. Everything doesn't quite line up right. This particular individual, if you're wondering, is absolutely asymptomatic. Um, you were actually seeing him for a hand injury on the opposite side, but he's been throwing baseball, athlete, and those sort of things. For the individuals, and this was, I forget, it was a keynote last year, who started talking about this.
What, AM?
But yeah, AM, and she talked about,
Well,
what's her
Cleveland
name?
was the main keynote.
She was one of the other.
Ah,
I forget. I'll have to pull it up. But
yeah.
she brought this up, this sort of stuff. And I would say, yeah, before kind of understanding that there's, poor posture and asymmetries, and that's what I wouldn't even bother looking. I wouldn't bother, rarely took off the shirt of the client. But when now during my examination, if I'm finding some issues with the scapula or scapulothoracic or the strength of those muscles, that's when I'll probably I'll ask him, hey, can I see these things? And if I'm already going to do some things to that scapular region and those sort of things, I might as well just try and see if I can link up what I see visually and, what they report and those sort of things. So I may play around with maybe this individual it's definitely abducted. Maybe I'll try and do some retraction, those sort of things, or they're extremely elevated. Maybe I'll do a kind of down glide of the scapula and those sort of things. And seems like it's been helping people quicker. There's going to obviously be some carryover of different muscles, not the ones that you're exactly targeting, and those individuals get better. But for me, anecdotally, individuals are experiencing their pain or elimination of their pain a lot quicker. Something we also didn't really mention, I'm putting more mind into the AC and SC joint a lot of the times. So I've had a couple cases where in normal cases I'm going to focus on thoracic, scapular, glenohumeral muscle stuff, and doing a deeper dive into seeing how they're not going to go into crazy like, oh my God, one's up, one's down. Understanding that's those asymmetries exist, but playing around with those joints. I've had some people, probably some of the quickest ones I had. We had one person had chronic shoulder kind of an impingement, was considering surgery, and just putting pressure inferior glide into the SC joint almost eliminated all his pain. Mobilized it for 5 minutes. It was examination, and he was pretty much symptom free. Saw him for a second session follow up, and he was completely done. So putting some time into that, it's something that blew off for probably a couple of years, in all honesty. And I was mentioned in PT school, I was like, meh. I think I gave up on it because I felt like I wasn't moving it much at all for a inherently stiffer, more stabilized joint. So I kind of gave up on those sort of things. But yeah, those are something I just wanted to kind of bring up. I know there's a lot of discussion in regards to that. And yeah, at this point, I just try to be as specific as I can, but don't kid myself anymore thinking I'm as specific as I am, if that makes any sense at all.
Yeah, agreed. And I had that kind of queued up actually here with the with a course that we're coming out with. And like you said, those patients, and this is where really manual therapy and good quality physical therapy comes into. I'm going to narrow it down, manual therapy. I guess in school we're taught everything we need to know, right? At least in theory of where to go, assess the joint above and below. But that gets lost very quickly as soon as you see somebody and somebody's talking to you and you're just a deer in the headlights look trying to figure it out. And it's very easy to get biased by I guess, just what we think it should be. So you just keep plugging away, and a lot of clinicians will just do some soft tissue to the delt because that's where the referred pain is. Some mobs, and they have them do their exercises. But those patients that get 70%, 80% better, and things are lingering, and it's like that for a couple sessions, take a step back and start treating some of those other areas that are interrelated. You said AC and SC joint. I mean, that clavicle, that SC joint needs to spin and depress for complete overhead range of motion. That's going to clear up a lot of that stuff there, especially something that's like, yeah, it's better, but I get there, it's still bothering me. Like mobilizations are only going to take you so far. Clearing up the T-spine is going to take you so far. Scapular assistance, maybe that helps, but what are you also doing? You're probably having an effect on the AC joint because the AC joint is made up from the scapula. So if you're gliding that up and assisting that, you're having an effect on the SC joint as well, or on the clavicle. I mean, that's where true manual therapy comes in, looking at things in combined motions. Taking a step back and not just looking at in one straight plane, but what other layer am I missing? Whether we talked last time about the ribs, second rib syndrome, whether it's really that, whether it's something else, like being able to go cervical spine, CT junctions, thoracic spine, ribs, scapula, AC joint, SC joint. Then you have all the muscles and timing and motor control issues, neurodynamics, whether it's ulna or typically it's median, but sometimes you can get ulna. Looking at these things. Sometimes, what if that person doesn't have full supination, or they don't have full wrist motion, and when they go to turn and open a door, they don't have supination, or they can't. So what do? They externally rotate their arm all the time. Creates aberrant motions. Like looking through the whole chain is where that separates those really good therapists from the not so good ones. It's that attention to detail.
And you're right. And I think it's somewhere in my as I see more overhead athletes and pitching and throwing athletes, something that I would do is like, at one point kind of generalize too much of like, all right, well, they need more thoracic mobility. Who doesn't need more thoracic mobility? And I started to, everybody gets foam rolls over the, extension over maybe a thread the needle and those sort of things, but starting to look as you're kind of alluding to, different positions and how they move throughout their daily life or sport, certain things like thoracic rotation, something that too many of us look at. If you lack thoracic rotation with the rowing, where is it going to end up? You have to make up for it at the shoulder junction, more external rotation. So I've had some people where I've done a specific thoracic rotation manipulation instead of the classic, say flexion or pistol or this type of motion that Brandon's putting up, and that cleared them up versus doing a standard extension one, because that's the easiest one. I'll do that. Okay, it seemed like you got better, didn't get all the way. Then do something a little bit more specific, and that's the ticket. So if we're not looking at it, we can't see it. Yeah, about to put up some videos there. Oh, they're done.
No, I could press play on them, but I was just showing, everything you were saying. Thread the needle, adding rotation. I think rotation, I concur with you, is overlooked, and it's probably the most important motion in the T-spine is rotation over extension. That manipulation with the bias that you showed, with the flexion bias, I think that's great. Most people live in extension anyway, and try and generate force, especially overhead athletes, weightlifters, things like that, CrossFitters, Olympic lifters. So can we bias them, into more flexion? Those people work kyphotic positions. Can we bias them to extension? I agree with you wholeheartedly there. I was going to add something else. Oh, weight bearing positions. Can you do some things where you're weight bearing? Actually, I have one here. It's actually could be used as a nerve glide too, and kind of going with that. And something that we've talked about with neurodynamics. I mean, she's weight bearing. She's putting weight through that. Can she protract on her left arm here as she reaches and rotates up through, is that going to lead to some neurodynamic stuff? Does she have the scapular stability to weight bear and protract through there? I mean, there's a lot of different things going on. Steve Kinney, one of the gentlemen, he's doing a poster presentation on neurodynamics, and he has combined neurodynamics from slump and upper extremity. Sometimes that may be needed in certain populations. Or mobilizing, we've had in our course, and we've talked about before, can you mobilize someone's T-spine or C-spine while they're doing neurodynamic to clear some stuff up a little bit more? Really combining treatments and getting out of this narrow view that we have that only one treatment can be done at one time and one intervention can be done at one time, which is what research a lot of times looks at. And then people poo-poo research because, well, it doesn't work or it says it's not effective. Well, when in actuality, you're doing one thing. In sports, in life, when is somebody just moving in a straight plane? They're typically moving loaded, while contorted, while carrying something, or while trying to generate a lot of force. A lot of things going on. Need to be able to understand that as well.
Yeah, I full-heartedly agree, and you got to look at it. In my presentation's also about combining joint mobs with neural mobs. And if you really look at what's happening, yeah, we're adding some compression or load to the joint itself, or gapping or moving it. We're moving the nerve. That patient's doing something active by generally helping you move their own leg. And if you're really good, you're talking and doing some education all at the same time, getting some blood flow and everything like that. So in one move, you can be doing 5 things that can all be beneficial for the client. And speaking of topics of neural dynamics, something looking back, now we're talking and those sort of things of, people with the referral pains and, impingement and stuff like that. I used to just always say, oh yeah, rarely do people feel shoulder pain in the shoulder. It's always down into the arm, into the belt area and that sort of things. And that's what hey, there you go. And how many times I probably blew off looking at neural dynamics. That sign was right there, and I just was like, oh yeah, that's normal, and just blew it off. So for those individuals, for our listeners at home, if you're hearing your clients say that the pain is more down the arm, and you're just like, yeah, it's part of the process, really, really look at, I think neural dynamics is probably very helpful, and there's a good chance that they're restricted or it's limited, and really get good at that testing of it, because there's a lot of times where I'm like, oh, okay, put them in a quick one. All right, good. No, it didn't hurt them. All right, we're fine. Where if I took it a little bit slower, probably was saw that I was like, you know what, they're probably missing 25% on this side. And maybe that's important. Maybe it's not, but maybe it is. So
And you won't know unless you assess it left to right. And not just do it half-heartedly, but really take people through all those steps and put some pressure on it and load them a little bit, especially more those chronic people.
And the exact same steps and degrees as you do the other side. Sometimes they're like, oh, their head slipped, whatever, fuck it. Right? But that changes your test. So definitely some things to think about when you're assessing neural dynamics, which everyone should be assessing, not just for impingement, but for a lot of things.
Kind of last thing here, if you don't mind, Jer.
I'm good.
Kind of some of the research. Minkin has a couple articles that look at cervical thoracic manipulations and exercise for patients with shoulder pain, and he had a criteria here. Let me see if I can pull it up. There we go. And so while this is the criteria, and he came out with this one, I believe in 16 or I believe, and was looking at pain-free shoulder deflection less than 127 degrees, IR less than 53 at 90 degrees, abduction, a negative near test, not taking meds for shoulder pain, and symptoms less than 90 days. And, it was thought to be that these people are going to respond to it. Then I believe the year later, they came out with a validation study, which actually proved that these factors aren't useful or successful, and we shouldn't be using these criteria in terms of rationalizing should we perform a thoracic manipulation or really cervical thoracic manipulation. Honestly, I'm still manipulating somebody with shoulder pain. Whether it's this exact criteria or maybe it's something else. A lot of these patients respond to it. Do they have to have less than 127 degrees? What if it's 130? 3 degrees off. What if it's 91 days? What if they're taking Tylenol, over-the-counter Tylenol? I just think, and I respect obviously Paul and Cleland and everyone else who did these research here, but just because their validation study didn't validate what they initially thought doesn't mean that we can't use, some of these techniques as a baseline to start to see if they respond to it. And maybe that response isn't all 100%, but maybe it gets them 30% better. And maybe that article, and we should probably do a podcast on just breaking up those two articles and why they didn't show the validation for people. But Cleland in 04 looked at performing thoracic manipulation for improving lower trap activation. To me, all right, if I'm not using manipulation because the Minkin article didn't validate it, well, how about with the mindset of, all right, thoracic manipulation is going to improve muscle activation around the parascapular region, and then I can layer into my treatment after that, some parascapular work, throwing T's and Y's, maybe weight-bearing protraction, maybe scapular plane wall angels or something like whatever exercise you choose, but now you're layering it. So just a piece of, I guess, advice for our audience out there.
Yeah, I think things that fail validation don't warrant the ability to think, oh, I shouldn't do that at all. It just means that, yeah, the things that they originally thought were the things that had the highest likelihood ratio of a successful outcome maybe aren't. It takes a lot to get validated in research, especially for like clinical prediction rules and stuff. Yeah. And maybe that's up to us to, as clinicians, to find out what is. Maybe obviously it takes work to do case studies and series and those sort of things, but maybe you're finding stuff that, every time I see this with this person and I do a manip or do this, it's money. All right, well, maybe I should, do a study on this. But yeah, combining multiple articles and those sort of things. But yeah, at this point, as we talked about, I don't put as much weight into following direct CPRs, and then when they don't get validated, because very few of them do, it's not time to just say, hey, I'm done with this. It's more, all right, I got to find a more specific way of when this is exactly going to work the best versus just doing it on everyone.
Yeah, because that article had, I think, 70 patients in each group. So you're trying to have 140 patients, generalized to the masses, and it just doesn't. So
it doesn't work for nobody. It doesn't matter what size article. We're too heterogeneous as a species to generalize that much. But yeah, good, all great talking points. I think that was your last thing that you wanted to bring up there, Brandon, and I think that's good. So thanks for listening in. Little housekeeping. Our next course will be December 5th and 6th.
Yep, December 5th and 6th in my office at Pursuit Butine, Verona, New Jersey. Approved for credits in both New Jersey and New York. So if you're in the area, please come check it out. It's usually one of our biggest or bigger courses that we have. What else do we have? Our mentorship platform. If you have any questions, please feel free to reach out to us. We'd be happy to help you out. It's the standard of, I guess, going through a residency or fellowship program, obviously with 3 staff members that have gone through both of those, access to over 600 articles, bi-monthly calls to talk about cases, private Facebook discussion group to synthesize articles, talk about patient cases, a lot of other resources that we have on there as well. And then we have our video library series that we offer out as well, over 120 manual therapy techniques with step-by-step instructions. We are continually adding to it and updating it. Actually, I have some neurodynamics I need to upload that we just recently shot. So give that a look. It's on can be found on the Pursue PT website as of now, but hopefully within early 2020 we will be kind of rebranding the Pursue PT education site and kind of get its own true platform there. So keep a heads out there. And now that I said it, I have to make sure I get it done. So
There we
that
go.
was a little mind trick against myself there. So I think that's pretty much it for wrapping up there. And then Jared, where can everybody reach us at?
You can find us at Nips and Sips on all major social media platforms. Feel free to subscribe to us so you know when episodes are dropping. And I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT Now. And he's got one more thing to say.
Yes, I do. One more thing. Check us out. We're going to be on YouTube soon. We're not on YouTube yet. Well, maybe when this drops, because it's probably not going to drop for a couple of weeks. But since what episode, I don't know, 20 or something, 15, we've started doing these Zoom
25.
recordings. So episode 25 on will be on there where you can actually see our lovely faces. We'll put the first videos up there, but we'll probably just have some photo over it, and you'll just have to listen to audio. So we are going to be entering into another platform on YouTube. So I know people maybe like to watch what they listen to or whatever, but we'll be on there as well.
There we go. Exciting times. But yeah, thanks for everyone for listening in, and cheers.
Cheers, guys.